Welcome back to the Deep Dive, where we take on some of the densest textbooks and research out there and really try to pull out the most actionable knowledge for you.
Mm-hmm.
Today, we are tackling a big one. It's a really critical mission. A deep dive into Chapter 17 of Baily and Love's 28th edition, focusing completely on pediatric surgery.
And this is it's a demanding chapter. So our goal today is very specific. If you're studying for exams or maybe getting ready for a rotation, our job here is to give you the context, those aha moments.
Right, the anchors.
The mnemonic anchors, exactly. The things that turn textbook facts into knowledge you can actually use. But, and I have to be absolutely clear here, this is our interpretation, our simplification.
Of course.
This deep dive is a revision guide. It's a ready reckoner. It is not, and I'll say it again, not a substitute for reading the official text. Use this to help you focus.
Absolutely. And our whole deep dive today really hangs on this one core idea that's right in the introduction to the chapter. Pediatric surgery is not just small adult surgery.
Fundamentally not.
From the anatomy, the physiology, the operating room, everything is different, and the stakes just feel so incredibly high.
They are, because the consequences of an error can be lifelong. And that whole concept of evolving anatomy, it really dictates the entire field. The chapter starts by pointing out this major trend, especially in high-income countries.
Subspecialization.
Subspecialization,
Yeah.
Exactly. Things that used to be squarely in the hands of a general pediatric surgeon, like, say, managing VP shunts for hydrocephalus or a complex cleft palate repair. They're now often handled by neurosurgery or plastics.
Which is great for those really complex cases, right?
Mhm.
You get an expert. But it does create a bit of a knowledge gap for the general surgeon, especially in other parts of the world.
It creates a crucial disparity, and the chapter gives a really important reality check here. In low-income settings, you just don't have those specialized resources.
Sure.
So the general surgeon there has to be competent in the core, life-saving general surgery of childhood. And that means mastering the things we're going to focus on today. The really common, high-acuity stuff. Inguinoscrotal issues, GI emergencies, the acute abdomen.
Okay, so let's get into those fundamentals, starting with the patient's size and physiology. It's even tricky just defining age, isn't it? Biologically, it's all a smooth continuum, but the healthcare system makes us use these, arbitrary cutoffs.
Yeah, 12, 16, 18. It depends on the service. But for us, precision in our language is absolutely key, especially when you're writing notes or doing a handover.
So what are the key terms we need to lock in?
Okay, so we're defining a neonate as less than 4 weeks old.
Yeah.
An infant is less than 1 year. The WHO defines adolescence as 10 to 19. And then for service planning, you'll often hear the term young people, which is 10 to 24.
And anchoring those is so important. A fever in a 3-week-old neonate is a completely different ballgame than in a 3-year-old.
A whole different world, exactly. And once we've got the age, we can dive into the anatomy, which brings us to our first big anchor. This one's from table 17.1. And the idea is, stop thinking of an infant's body as just a miniature adult. Instead, you need to think of the infant's abdomen as a wide, shallow dish.
I like that, a wide, shallow dish. So what does that metaphor actually mean for a surgeon?
Well, it immediately changes how you think about getting access.
Yeah.
An infant has this wide abdomen, a really broad, flaring costal margin, and a surprisingly shallow pelvis.
So a standard vertical midline incision isn't always the best approach.
It's often not. Because of that architecture, a transverse supraumbilical incision going across often gives you much, much better access. You're using that natural width to your advantage.
And the shallow part of the dish, that has some pretty big implications for the organs inside, right?
Huge implications. It brings really important organs dangerously close to the surface. The risk is magnified. For example, the liver edge in an infant naturally sits below the costal margin. That's a huge difference from an adult. And similarly, the bladder is partly an intra-abdominal organ, not tucked away in the pelvis. So the clinical takeaway is massive. In abdominal trauma, or even just making a standard incision, you are at a much higher risk of accidentally damaging the liver or that partially exposed bladder.
And these structural differences, they go upwards too, into the chest. The ribs are more horizontal and they're way more flexible.
And that flexibility means that infants rely much more on their diaphragm for breathing. Their intercostal muscles just don't do as much of the work.
So anything that pushes up on the diaphragm, like a distended stomach, is going to affect your breathing way more than in an adult.
Far more profoundly, yes. And one last little detail on this, a topographical point that actually impacts stoma care. The umbilicus is lower lying.
A simple point, but one I imagine is easy to forget.
It's a critical one. If you have to place a stoma in an infant's lower abdomen, you've got to be so careful about where you site it to make sure the bag doesn't interfere with the umbilicus. A poorly placed stoma bag can cause all sorts of problems with skin breakdown.
So this difference in scale and anatomy leads us right into environmental sensitivities. When a child is on an operating table, one of the biggest dangers isn't the surgery itself, but heat and fluid loss.
Yes, which gives us our next anchor. You need to think of the infant as a high surface area radiator.
A radiator, okay.
It's just basic physics. Compared to their body weight, kids have a much, much higher surface area to weight ratio. So they are just radiating heat and losing water through their skin at a much faster rate than you or I would.
And the best example of that is the head, isn't it?
It is, yeah. An infant's head is about 20% of their total surface area. For an adult, it's maybe 10%. So that massive, highly vascular area is just pumping out heat. It makes them incredibly susceptible to hypothermia.
And hypothermia in surgery is more than just feeling cold. It's dangerous.
Oh, it's incredibly dangerous. It impairs how your platelets work. It increases your risk of bleeding. It can worsen metabolic acidosis. And it even increases oxygen consumption because the body is trying to shiver to stay warm. It can derail a whole procedure.
So what do you do about it?
You have to be proactive, always. In the operating room, you are actively using warming strategies. Overhead radiant heaters, heated mattresses, warm air blowers, and you make sure all the respiratory gases are warmed and humidified. It's a constant battle.
This intense physiological sensitivity, it takes us right to what is probably the cornerstone of all pediatric surgical care, perioperative fluids. Getting fluids wrong is a huge pitfall.
It is probably the single most common iatrogenic error made by junior staff. It's the most critical domain to master. Before you do anything, you have to assess their current state.
Right, look for signs of dehydration.
Exactly. Moderate dehydration, say 5% loss, you might see dry mucous membranes, low urine output, a sunken fontanelle. Severe dehydration, over 10% loss. Now you're talking systemic compromise, tachycardia, drowsiness, a capillary refill time over 2 seconds.
The source material gives us a great way to structure this whole discussion. A mnemonic, the 4 R's of IV fluids.
Yes. The 4 reasons you'd give IV fluids. First, for acute circulatory support, that's resuscitation. Second, replacement of previous deficits from, say, vomiting. Third, replacement of ongoing losses, like from an angina. And fourth, just maintenance fluids.
Let's start with that first R, resuscitation.
Yeah.
The child is acutely unstable. What's the approach?
The approach is standardized. You give rapid boluses, usually of an isotonic crystalloid like 0.9% saline. The dose is 10 or 20 millirels per kilogram of body weight, given over, say, up to 20 minutes.
And the key is to keep reassessing.
Constantly. You give the bolus, you watch their response. Does the heart rate come down? Does their capillary refill get quicker? And there's a clear stopping point.
What's that?
If you've given 40 millirel per kilogram of fluid and the child is still unstable, you stop. You stop giving boluses and you get senior help immediately. That threshold tells you something else is going on, a massive ongoing bleed, maybe a cardiac issue that crystalloids alone can't fix.
Okay, so that's the crisis. What about for an elective patient, or once things have stabilized? We move to calculating daily maintenance fluids.
Right. Using the holiday cigar rule, this is foundational. You just have to know this by heart, both the daily and the hourly rates.
Did you break that down for us?
Sure. It's segmented by weight. For the first 10 kilograms of body weight, it's 100 millilels per kilogram per day.
Which works out to 4 millimels per kilo per hour.
Exactly. For the next 10 kilos, so from 10 to 20 kilograms, it's 50 millilels per pico per day.
2 mLs per kilo per hour.
Right. And then for every kilogram over 20, it's 20 millilels per kilo per day, which is 1 millilels per kilo per hour.
So for a 25-kilo child, just to walk through it, that's 1,000 for the first 10, 500 for the second 10, and then 5 times 20, which is 100. So 1,600 millilels per day.
Perfect. Exactly right. And just a quick note, neonates are the exception. They often need a bit more, maybe 120 to 150 millilels per kilo per day, but that's adjusted very carefully based on their bloods and weight.
Now we get to the biggest trap of all, the risk of hyponatremia, low sodium, which can lead to cerebral edema. The chapter explains why this is such a huge risk after surgery.
We call this the ADH trap, and there are 2 things that are conspiring against the patient here. First is the fluid you choose to give.
Right.
But the chapter is explicit. Do not use highly hypotonic 0.18% saline outside of the neonatal period. Even 0.45% saline in 5% dextrose is a problem
Why is that?
because your body metabolizes the glucose almost instantly, leaving behind free water. So that solution effectively becomes hypotonic, and it just dilutes the serum sodium.
Then the second factor is the body's own stress response to the surgery.
Yes. Any major surgical stress, any trauma, pain, it causes an inappropriate spike in antidiuretic hormone ADH, and ADH's job is to retain water to keep your circulating volume up.
So when ADH is high, the kidneys just hang on to water and urine output naturally goes down.
It goes down, and here is the pitfall. The junior clinician sees that low urine output on the chart and immediately thinks, oh, the patient is dry, they're hypovolemic.
So they give more fluid.
They increase the maintenance fluid rate. But if ADH is already inappropriately high, all that extra fluid just gets retained. And that leads directly and rapidly to dilutional hypernatremia.
Wow. Okay, that's such a critical point. So let's pause here and put this into a quick scenario for everyone listening. If you need to, just hit rewind and listen to that ADH trap explanation again, because it is vital.
Okay, here's the check-in question. A 7-year-old child is 12 hours post-op from a splenectomy. You know their urine output has dropped to 0.4 milliliter GGH, but they look well. Their heart rate is normal. Cap refill is brisk. What is the single most important thing you have to confirm before you even think about giving a fluid bolus, and why could that bolus be really harmful here?
And the answer is you have to confirm that there are actual signs of hypovolemia. Is there tachycardia? Is there perfusion poor? In this scenario, the child is likely normovolemic. That low urine output is the expected effect of high post-op ADH.
Exactly. So giving a fluid bolus just to chase a number on a chart will overload them with free water, could tip them into symptomatic hyponatremia.
And if that happens, what's the management?
If it's mild, asymptomatic, you just restrict fluids. But if they're symptomatic lethargic, having a headache or, God forbid, a seizure, and their sodium is critically low, say less than 125, that's an emergency. You have to give hypertonic 3% saline to protect the brain.
Okay, before we get into specific conditions, let's talk about the operating room itself. What are the key principles that make operating on a child so different beyond the physiology we've covered?
It really all comes down to meticulous technique. The chapter is very clear on this. You have to handle the tissues so gently. Strict hemostasis is mandatory. Even small blood losses can be significant in a tiny patient. You're using fine sutures, often with magnification.
And there's a specific detail about wound closure, especially in thin children.
Yes, the focus is on creating layers. You have to make sure you get a layer of fat between the skin and the muscle. If you let the skin adhere directly to the muscle, it can tether and cause problems down the line. We use absorbable subcuticular sutures or skin glue to be as kind to the skin as possible.
Right, let's shift from general principles into some specific high-yield conditions. We're heading into the world of inguinoscrotal disorders.
And to understand this, we need an embryological anchor. As the testis descends, a little finger of peritoneum, the processus vaginalis, goes down with it. The pathology of both hernias and hydroceles comes from the failure of this tunnel to close. So our anchor for this section is the vanishing tunnel.
So if this tunnel fails to vanish, what happens?
Two things can happen. If it stays wide open, you get an indirect inguinal hernia. Abdominal contents can pop through. If it closes just partially, trapping some peritoneal fluid at the bottom, you get a hydrocele.
Okay, let's start with inguinal hernias. What are the key facts?
They affect about 4% of infants. Prematurity and low birth weight are big risk factors. They are way more common in boys, about 6 to 1, and twice as common on the right side. About 10% are bilateral.
And the presentation is usually just an intermittent bulge that gets worse when they cry or strain?
Usually. But we need to know about the contents. You have your standard intestine and omentum, but you also have the eponyms. An amnion's hernia contains the appendix, and a Leader's hernia has a Meckel's diverticulum.
And in girls, it can be a real emergency.
A huge emergency. An ovary can prolapse into the sac and twist. That needs immediate surgical repair.
But the real game changer for any hernia is incarceration. What are the red flags?
The red flags are when the contents become firm, tender, and irreducible. The parents will tell you the bulge won't go away. The child is irritable, often vomiting. If you suspect incarceration, you can try gentle, sustained pressure to reduce it.
And if that fails?
It's an immediate surgical emergency. You have to explore, reduce, and repair Time is absolutely critical.
And the repair itself, whether it's open or laparoscopic, what's the goal?
The goal is the same for both. High ligation of that patent sac right at the internal ring. In an open repair, you have to be so careful dissecting the delicate sac away from the voes and the vessels. Laparoscopically, you place an encircling suture around the neck of the sac.
Okay, now let's talk about hydrocele, the trapped fluid. These are usually asymptomatic, right?
Right. They're usually confined to the scrotum. They're non-tender. A key differentiator is that they often fluctuate. They might reduce a bit overnight as fluid seeps back into the peritoneum. But here is the big caveat the chapter stresses: transillumination.
Ah, the classic test we're all taught. But the authors warn against relying on it in infants. Why is it so flawed?
Because infant tissues are so thin, light shines right through them. So if you have an incarcerated hernia with fluid-filled loops of bowel inside, it can actually transilluminate.
Oh, wow.
You could disastrously mistake a surgical emergency for a benign hydrocele. You have to rely on the physical exam. Is it tense? Is it tender? Can you reduce it?
So what's the management for a simple hydrocele?
We wait. The time frame is 2 years. Surgery is very rarely done before the age of 2 because the vast majority just resolve on their own as that processus vaginalis finally closes. If it's still there after 2, then surgery is indicated.
Okay, so we've covered the 2 outcomes of that vanishing tunnel. Let's do a quick check-in to really anchor the physical exam findings.
Okay, check-in question. You're examining an 8-week-old infant. The parents say there's a swelling in the scrotum that goes away completely when the baby sleeps, but it feels tense when he cries. It's not tender. Is this more likely an incarcerated hernia or a large communicating hydrocele? And what physical maneuver gives you the most confidence in your diagnosis?
The big clue there is the complete reduction overnight. An incarcerated hernia is stuck. That fluctuation points strongly to a communicating hydrocele. And the maneuver, it would be trying to feel the spermatic cord above the swelling. If you can feel the cord clearly above the fluid, it's a hydrocele. If the swelling goes all the way up and you can't get above it, it's a hernia.
Excellent. Exactly right. Okay, let's move on to the other big inguinoscrotal issue, undescended testes, or UDT.
Right, so normal descent is usually done by the 30th week of gestation, but it can continue after birth. We need a clear timeline anchor here for when we stop waiting and start intervening.
Our UDT timing anchor is 3 months. The window for spontaneous descent closes at 3 months of age. If a testis is still undescended then, it is very unlikely to come down on its own. So we schedule surgery and orchidopexy early, between 6 and 12 months.
And why the urgency? Why so early?
2 main goals. You want to get that testis into the cooler scrotal environment as soon as possible. This gives the best chance of optimizing future spermatogenesis, future fertility. And it may also reduce the long-term risk of malignancy, though there's still some debate on that.
Clinically, there are a few different types of non-scrotal tests. We need to be able to tell them apart. What's the difference between a retractile and an ascending testis?
A retractile testis is very common in young boys. You can find it in the groin, and you can gently bring it down into the scrotum, but as soon as you let go, it snaps right back up. That's an overactive cremasteric reflex. Most of these sort themselves out, but they need follow-up.
And an ascending testis.
An ascending testis is different. This is a testis that was documented as being in the scrotum in infancy, but now it's high up in the groin because the spermatic cord didn't grow enough as the child grew. These always need an orchidopexy.
And the big red flag we absolutely cannot miss.
Bilateral impalpable UDTs with hypospadias. If you find that, you have to stop. It's a huge red flag for a disorder of sexual differentiation, and that child needs an urgent specialist referral.
So let's talk surgery. What's the procedure for a palpable UDT?
For a palpable one, you do an inguinal orchidopexy. You open the inguinal canal, you carefully mobilize the testis and the cord, and you ligate the little peritoneal remnant at the internal ring. The key is getting enough length on that cord before you bring the testis down and secure it in the little pouch in the scrotum.
But the impalpable UDT is a bigger challenge. What do we do when we can't feel the testes at all?
First, imaging is unreliable. Don't waste time with ultrasounds. The gold standard is an examination under anesthesia, followed immediately by laparoscopy, usually at around 1 year of age. What you find with the camera dictates what you do next.
And what are the possibilities?
3 main things. 1, the testis is just absent. You'll see the vas and vessels ending blindly. 2, the vessels and vas go into the internal ring, which means the testis is in the canal, so you proceed to an open exploration. Or 3, you find a high, viable testis way up in the abdomen.
And that last scenario brings us to another high-yield surgical anchor, the 2-stage Fowler-Stevens orchidopexy.
This is a brilliant procedure. A high intra-abdominal testes has a short blood supply coming straight from the aorta. You can't bring it down in one go. So in stage 1, you strategically ligate those main testicular vessels, and you leave the testes where it is.
You're essentially betting that the collateral blood supply, the smaller vessels that run with the vas deferens, will be enough to keep it alive.
You are. You're betting on those vasal vessels to hypertrophy. Then you come back 3 months later for stage 2. If the testes has survived and that collateral supply has developed, you can now mobilize it and bring it down into the scrotum. It's a complex but really elegant solution.
Okay, we're transitioning now from chronic issues to the most time-sensitive emergency of the male genital tract, the acute scrotum.
Yes, and like the acute abdomen, time is everything here. Our anchor for this is testicular torsion, the ticking clock emergency.
This is a twist of the spermatic cord, cutting off the blood supply. What should make us immediately suspicious?
Acute onset, severe scrotal pain. The pain can be referred to the abdomen or groin, and it is almost always accompanied by nausea and vomiting. That's a key differentiator.
And on examination, what are the classic signs?
Tenderness, swelling, and importantly, an absent cremasteric reflex. That's the reflex where stroking the inner thigh makes the testes rise. In torsion, that's gone. The testes also often rides high in the scrotum because the twisted cord is shorter.
A Doppler ultrasound can show absent blood flow, but if you're suspicious clinically, you don't wait, do you?
Absolutely not. The clinical picture is king, and our time anchor is critical. Salvage rates plummet after 6 hours. You must get that child to theater for exploration within 6 to 8 hours of the pain starting.
And in the OR, what's the plan?
Immediate detorsion. You untwist the testes, wrap it in warm packs, and you wait to see if the color comes back. And a key point here, you only take out a testes that is completely, obviously gangrenous. If it's borderline, you leave it. And critically, you then fix both tests, the affected one and the contralateral one, to prevent it ever happening again.
Now, in contrast to that, there's the much more benign condition that can mimic it, torsion of the testicular appendage.
Yes, the benign imitator. This is a twist of a tiny little remnant, the appendix testes. It's most common between ages 7 and 14. The pain is acute, but it's usually localized, and crucially, it's typically without the nausea and vomiting you see in true torsion.
And it has that classic, almost diagnostic sign.
It does. The blue dot sign anchor. You can sometimes see a small dark nodule through the scrotal skin, which is the infarcted appendage. And importantly, the cremasteric reflex is usually present and normal.
So management here is conservative.
Yes, rest, analgesia, support. You only go to surgery if you're not 100% sure it isn't a true testicular torsion.
Okay, let's move into the abdomen and tackle the two classic life-threatening GI emergencies of infancy, pyloric stenosis and intussusception. Let's start with infantile hypertrophic pyloric stenosis, or IHPS.
Our anchor for IHPS is to think of the pylorus as the olive obstacle. The muscle of the pylorus gets really thick and long, creating a physical blockage. It usually presents between 2 and 6 weeks of age, more common in firstborn boys. And the classic symptom is non-bilious projectile vomiting.
And the one detail that really distinguishes it from simple reflux is the infant's behavior right after vomiting.
It's the postprandial hunger. The baby vomits violently, empties their stomach, and then immediately cries because they're still starving. They want more milk.
On examination, you might see waves of peristalsis moving across the abdomen, and you might be able to palpate that olive mass in the right upper quadrant. But before surgery, resuscitation is the priority.
Absolutely. Because they've been vomiting pure gastric acid, they develop a very specific metabolic derangement, a hypochloremic, hypokalemic metabolic alkalosis.
And correcting that requires a very specific fluid.
It does. Our fluid management anchor for IHPS is 0.9% saline with potassium chloride and 5% glucose given at a high rate. Correction can take 24 to 48 hours. And replacing the chloride is the key because once the chloride is replaced, the kidneys can finally correct the pH imbalance.
Once they're stable, the treatment is a Ramstedt's pyloromyotomy.
Yes. You incise the serosa and carefully spread the muscle fibers apart, leaving the mucosa underneath intact. The key is to make sure your incision is long enough, extending right onto the stomach to prevent it from recurring.
Okay, let's move to the second big one. Intussusception. Our anchor is the telescoping intestine.
This is typically seen in slightly older infants, usually between 2 months and 2 years. Most cases are ileocolic, where the ileum telescopes into the colon. And in this age group, it's usually idiopathic, probably triggered by a virus that makes the lymph nodes in the gut wall swell up.
But if the child is older than 2, or it keeps happening, You have to think about a pathological lead point.
Exactly. Then you start thinking about things like a Meckel's diverticulum or even a lymphoma acting as the lid point.
The clinical presentation is really striking.
It is. You have a previously well baby who suddenly starts having these episodes of intense colicky pain. They scream, they go pale, they draw their legs up. But crucially, in between the episodes, they can seem surprisingly well.
And the classic late sign is the red currant jelly stool.
Right, which is blood mixed with mucus. But that's a late sign. The intermittent colic is your biggest clue. You might also feel a sausage-shaped mass in the right upper quadrant. Diagnosis is confirmed on ultrasound, which shows that classic concentric target sign.
And management starts with resuscitation, but the definitive treatment isn't always surgery, is it?
No, the first-line treatment is a non-operative air reduction enema, and it's successful in over 70% of cases. You watch under fluoroscopy as the air pushes the bowel back into place.
But there are times when you absolutely cannot do an enema.
Correct. If the baby has signs of peritonitis, a perforation, or is in shock, that's an absolute contraindication. You go straight to the operating room for a surgical reduction or, if needed, a resection of any dead bowel.
Okay, we've covered two huge GI emergencies that both present with vomiting, but they were so different. Let's use a final case study to lock this in.
All right, case study check-in. You're in the ER. Infant A is 6 weeks old with projectile vomiting. After every vomit, he is ravenous. Infant B is 10 months old with episodes of inconsolable crying every 20 minutes. In between, he's lethargic. You find a palpable mass and some bloody mucus in his diaper. Which infant is at risk for hypochloremic alkalosis, and which one needs an urgent ultrasound for a telescoping bowel?
Okay, so infant A, the 6-week-old who is hungry after vomiting, that's classic pyloric stenosis. He's the one at risk for that specific metabolic alkalosis. Infant B, with the waves of colic and the mass and the bloody stool, that is classic intussusception. He needs an immediate ultrasound.
Perfect. Okay, let's broaden out now to the very common challenge of acute abdominal pain in children, with acute appendicitis being the #1 surgical cause.
And we need to focus on the pitfalls here because diagnosis, especially in the little ones, can be really, really tough.
It can. The classic story we all learn is low-grade fever, anorexia, vomiting, then central pain that moves to the right iliac fossa with guarding. That persistent, localized guarding is what separates it from non-specific pain.
But what are the pitfalls, especially in kids under 5?
Okay, pitfall #1, misdiagnosing it as gastroenteritis. Sometimes an inflamed appendix can irritate the bowel and cause loose stools. Pitfall #2, misattributing urinary symptoms to a UPI. If the appendix is low in the pelvis, it can irritate the bladder and cause dysuria or even pus in the urine.
That's a huge trap.
It is. Pitfall 3 is referred pain. Always think about a right lower lobe pneumonia irritating the diaphragm. And the final, most important factor is that in kids under 5, diagnosis is harder, their signs are more subtle, and because their omentum is less developed, perforation happens much, much more often.
Okay, let's quickly cover a few other common conditions before we get to oncology. Midline hernias.
Right. Umbilical hernias are super common and almost always resolve on their own by age 4. But supraumbilical and epigastric hernias, which are higher up, they do not close on their own and will need surgical repair if they're causing problems.
And now, one of the scariest things for a parent, foreign body ingestion. We need a clear anchor for the most dangerous objects.
Yes. Our final anchor is the foreign body danger anchor, and it's all about location and object type. If an object is stuck in the esophagus, it has to come out endoscopically. The single most critical danger is a button battery.
Why is a button battery so much worse than a coin?
It's not just a blockage, it's a chemical burn. The battery creates a current that generates hydroxide, an alkali which causes rapid, deep liquefaction necrosis. A button battery in the esophagus needs to be removed within hours before it perforates into the trachea or even the aorta.
And what about magnet?
Ingesting multiple magnets is also incredibly dangerous. If they're ingested at different times, they can attract each other across different loops of bowel, causing pressure necrosis and forming a fistula or perforating. That's a surgical emergency.
Okay, one final topic before we conclude. Pediatric surgical oncology. We're focusing on the two giants of the abdomen.
Neuroblastoma and Wilms tumor. Neuroblastoma arises from neural crest cells, usually in the adrenal medulla or sympathetic chain. It often presents as a firm, irregular mass and is associated with high levels of urinary catecholamines.
And treatment depends on the stage.
It does. Small, localized tumors are removed surgically. But advanced tumors often get chemotherapy first to shrink them down before surgery is attempted. The prognosis really varies with stage.
And the second giant is Wilms tumor.
Wilms tumor, or necroblastoma, is a malignant kidney tumor. It usually presents as a smooth, firm abdominal mass in a child between 1 and 4 years old.
And how does that affect the surgical approach?
These tumors can be very aggressive locally, even extending into the vena cava. So, like neuroblastoma, they often get chemotherapy before surgery to shrink them and make the nephrectomy safer. Thankfully, the overall survival rates are actually quite good.
That was an incredibly detailed tour of a huge chapter. Let's try and distill this down into the absolute highest yield concepts for revision.
Okay. If you take away just 4 things from this deep dive, you'll be in a great place. 1. Fluid management. Know the 100-5D-20 rule and understand the danger of the post-op ADH trap leading to hyponatremia.
2. Inguinal-scrotal pathology. The vanishing tunnel is the link between hernias and hydrocele, and you have to rely on your physical exam, not on transillumination.
3. The acute scrotum. Testicular torsion is a 6 to 8 hour emergency. The key signs are pain with vomiting and an absent cremasteric reflex. This separates it from appendage torsion with its blue dot sign.
And 4. GI emergencies. You have to be able to distinguish projectile vomiting with postprandial hunger, which is pyloric stenosis, from the intermittent severe colic and red currant jelly stool of intussusception. This deep dive has really filtered out the critical concepts and the clinical traps from the Baily and Love chapter. But remember, to get the full context and all the details, you have to go back to the source material itself.
And just to take one final step back, think about the weight of what we've just discussed. We talked about conditions with these incredibly narrow time windows, 6 hours for a testes, maybe a few days for a button battery. It raises a bigger question for you to think about. What is the lifelong legacy of a misdiagnosis in a child? How does the potential for something like infertility after a delayed orchidopexy or chronic illness from a neglected foreign body, how does that shape the ethical imperative for decisive action in this really unique and challenging field?
That intersection of urgency and just profound lasting consequence, it really defines the unique responsibility of the pediatric surgeon. Thank you so much for joining us for this deep dive. We hope you feel anchored and prepared.